Alrighty, good morning everyone, and thank you for tuning in to week 8, back from midsummer break. So we're going to start off with the last section of anatomy you guys will ever do in year 1, apart from cardio, but that doesn't count, which is back anatomy. So as a preface, back anatomy is not very important at all, and I don't think many of us in year 2 have even studied it last year much, apart from the bones. So I have a lot of detail in the slides, but it's very low yield, and just focus on bones and pathologies and you guys will be fine. So starting off with the spinal column. So we have a vertebral column, wow. And basically it has 5 different sections, and every single section has bones that look slightly different. So we start off with cervical, the 7, 12 thoracic vertebrae from your neck to your tummy area, lumbar vertebrae, which is your lower back, and then you have your sacrum and coccyx, and these guys are all fused together into like one big bone. And do remember how many bones are in each section. You can remember it by like the times in which you eat food throughout the day, 7, 12, 5, and 9, because you will want to know that. So for each individual bone, there's 2 general parts. There is a body and there is a vertebral arch. The body is basically like the big flat weight bearing thing that's in between discs, and the vertebral arch we'll get to in a second. So within the vertebral arch, we have 2 types of like bony things. We either have processes or we have lamina, which are bones that connect the bony processes. So we have a process at the back, which you can palpate on yourself, the spinous process. We have 2 transverse processes, like 2 wings on the side, a superior articular process. These are used to basically form joints between like each vertebrae and the one above and below. And then the lamina connects these 2, and the pedicles connect these 2 processes. That's about it. So as we said, every section of vertebra looks kind of different. First of all, the cervical vertebrae, which start from the base of your skull all the way to your neck area, because some of the brachial plexus is here, remember? They have 3 special things about them, I guess. First of all, they have a bifid spinous process. So instead of 1 bumpy thing, they have 2. Next, the vertebral foramen. This is where the spinal cord or the nerves run through. This is like a triangular shape, which really isn't high yield, but there you go. And you have transverse foramina. So remember, in these little wings over here, the transverse processes, within the cervical vertebrae, they're a lot more rounded and they have a hole in the middle. And the reason why that's like that is because we have vertebral arteries that travel to the brain, whereas we don't need that anywhere else in the body. It's important to remember that C1 and C2 are called Atlas and Axis respectively. Atlas is like the Greek titan that like held up the world as like a punishment or something. So just imagine C1 is like the bone that holds up your skull, like Atlas holding up the world. These 2 look kind of different. They can get broken easily, so there are some pathologies there when you like land on your head or something. So they're specialized for head movement, so remember those 2. Moving down to your back, we have 12 thoracic vertebrae. These are slightly bigger, they're medium-sized, and the specialization with these is for rib articulation. So what's special about these is that they have demifacets and a costal facet. Basically, these are just little grooves in which a rib runs through before it attaches to the manubrium of the sternum at like the anterior side of your chest wall. So a demifacet is where like the origin, the head of the rib attaches, and the rib kind of moves inferiorly, articulates with the costal facet, and then moves around to the front. And yeah, the spinous process here, they're really long and they cover the vertebrae of the one that it's below, yeah. So it's really long compared to all other spinous processes, but that's basically it. Now for your lower back, your 5 lumbar vertebrae are special because they're the simple guys. They just look like little kidney beans and they don't really have any special bumps on them, which is, I guess, their own specialty, which is having no specialty. And I guess the spinous processes are shorter than all the other ones. And the reason why they look like this is because your lower back is built to absorb a lot of pressure and hold up, you know, the rest of your body, which is why they're so big and flat. But your lumbar vertebrae is important clinically because this is the area in your lower back where we do a lot of procedures like epidurals, basically just injecting anesthesia for surgery or for pregnancy, delivery, lumbar puncture, stuff like that. There's good access to the spinal canal and the spinal cord here between each vertebrae, because you can imagine here it's pretty hard to get to the spinal cord because it's covered by the large spinous process and everything, but in the lumbar vertebrae it's a lot easier. And now finally, for the sacrum and the coccyx, remember these do not form part of the hip bones. They actually are a part of the vertebrae instead. Basically, the sacrum is 5 fused vertebrae and the coccyx is like 4 tiny fused vertebrae. And I guess the importance of these is that they just articulate with the hips to form different like sacroiliac joints and stuff. And you can have clinical pathologies where the sacrum starts separating, or basically the S1 of the sacrum separates from the rest, and we call that lumbarization, and the fusion of L5 to the sacrum is termed sacralization. So those are just some congenital abnormalities, but pretty low yield again. Okay, now clinically speaking, in clinical seals, you would have, like pre-COVID, had to do some palpation. So it's important to remember some of the surface landmarks of the vertebrae. So starting from here, you have the C7 spinous process, which you can palpate on yourself as the largest spinous process you can feel on your body. That's just at the base of your neck. And from there, you can count down T1, T2, and so on and so forth. The neutral groove is the area above C7. C1 is somewhere around here, the atlas holding up the head. Here, S2, this is another point to remember because these two are like the dimples of Venus. And they're clinically important because they overlie the PSIS. They're on the line of S2, just remember that. Yep, and also it would be good to remember one more thing, which is a sacral triangle here. This is just a little triangle where you can get like pain, I guess, when you hurt your low back. And you can remember this because this is on the line of S2. This line is formed between the two PSISs, and the two triangles extend down to your intergluteal cleft, like the top of your butt cheek, and the coccyx is right below that. Okay, ligaments. So ligaments are slightly less important than bones. You should remember the different parts of the bones, by the way, because I think there were a couple of exam questions about like identifying what kind of vertebrae belongs to what part of the body. But ligaments are also important as well, so do try and remember these 5. It's pretty simple though, pretty straightforward. Basically, there's 2 longitudinal ones, which just run anterior and posterior of the vertebral body. This prevents your back from flexing or extending too much and hurting yourself. We have the ligamentum flavum, which is just in between each vertebrae, and the interspinous and supraspinous. Remember, inter is inside, supra is on top of, which indicates their position, and this basically joins each vertebrae to the one above and below it. For the intervertebral discs, all you have to remember is that there is a nucleus and the annulus fibrosus that make up each disc. And whenever we have pathology and pain, we talk about like your disc herniating or whatever, or bulging out, that's your nucleus that's the issue, not the annulus fibrosus. So in a disc bulge, disc herniation, basically the nucleus pulposus gets out and compresses the spinal nerve, and this is how you create back pain. Now to the muscle layers. Again, this is not too high yield. I would honestly say just remember this table. I have a lot more stuff here, but this is the really high yield stuff. So again, with muscles, we have layers. We have 3 broad layers, which are the superficial, intermediate, and the deep, aka intrinsic layer. And within the intrinsic layer, we have 3 superficial, intermediate, and deep. Really original. So the thing to remember with back muscles is that they kind of for the intrinsic ones at least, they have a collective name for a group of them. So in the superficial layer of the deep layer, we have two muscles, the capitis and the cervicus, and we call these together the spinotransversales. Moving down, we have the erector spinae. This is really important because these three muscles, which form the erector spinae, are in charge of doing all the flexion and extension of your back and your head and neck. And your intrinsic, your deep muscles are called transversospinales. Just remember, like S for superficial, S comes before T, and the erector spinae is a strong thing within the middle of them. The intrinsic, like the deep muscles, are for proprioception and stability. The superficial deep muscles are for moving your head and neck because they're just at the top here. And now back to the actual superficial muscles at the very top. They're just the trapezius, latissimus dorsi, stuff you probably covered in upper limb, and they're in charge of upper limb movement. Intermediate muscles, there is literally one, which is a serratus posterior inferior, and that can move the ribs. You can kind of tell because the ligaments connect like that, like ribs do. They look like ribs, I guess. But yeah, just remember the type of muscles they are, and I think it would be good to memorize each one of these names, but don't bother with much else. So this is all just for just if you're interested in reading. So let's move on to the spinal cord. Now, what are the nerves running through the spinal canal? These are the spinal cord nerves, and basically it starts from the pons, ends as a little filum terminale, and there's two areas where the nerves kind of bulge, because remember, this is like a really it's like a really dense amount of nerve tissue, like running down together like a little column. You can't really see it as like individual nerves, but in the area of C4 to T1 and T11 to L1, it kind of enlarges. And the reason why is because these are where we have plexi originating, the brachial plexus and the lumbosacral plexus. Do not bother memorizing the lumbosacral plexus though. But yeah, that's basically it. This travels within the spinal canal. It's surrounded by cerebrospinal fluid and spinal meninges, which are just layers of like glad wrapping around it, protecting it. And below the conus medullaris, so below the level of like L1, L2, it stops becoming such a dense column of nerves. Instead, it kind of becomes like a horsetail, the cauda equina basically, and it all splits and forms individual nerves, if that makes sense. Okay, so for the spinal meninges, the three membranes, these are analogous with the cranial meninges, so as they travel up, they also cover the brain as well. They're important for containing cerebrospinal fluid to protect the spinal cord, and the filum terminale at the bottom, below the cauda equina, is actually all the meninges sticking together and forming like an anchor to hold the entire nerve, the entire spinal cord like upright. So spinal meninges, we have three layers, the dura, arachnoid, and pia mater, so memorize these three. The clinically important thing is the subarachnoid space. So beneath the arachnoid mater, you can kind of see it here, subarachnoid space. This area is really important because this is where we find the CSF, and we have clinical applications where we need to like drain CSF to like test for blood or meningitis to see infections and stuff. So remember the subarachnoid space. So, okay, so the spinal nerves are basically nerves which exit the spinal cord, and they're mixed nerves because they have both motor and sensory functions, whereas some nerves in your body are purely motor or purely sensory. So these form the peripheral nervous system because remember, spinal cord and brain is central, everything else is peripheral. And basically after they leave, they kind of like fuse together to become a mixed spinal nerve, but then after that they split yet again to form an anterior ramus and a posterior ramus. This is kind of S1, semester 1 revision, but do remember this because the posterior ramus it's very small, as you can see here, because it only supplies nerve fibers to like your vertebral column, some of your back muscles, some of the skin above your back, Whereas the anterior ramus is like so big and chunky, so it goes to the rest of your body, to your fingers, to your toes, innervating everything else. And there's a spinal nerve exiting under every single spinal bone. Vertebrae, vertebrae, except for C1 where there's also one exiting above. So the 31 pairs in total, 8 pairs in the cervical nerves to so that there's one above C1 as well. All right, so vasculature, I don't think we even went over this, but if you're curious, you can read that here. Okay, now let's get into a bit of pathology. We'll just speed through it. But the first thing to remember is cauda equina syndrome. This is a syndrome where you can have pain down your back and legs because there's a lesion below L2 vertebrae causing these nerve roots to have a lot of pain. And remember, we said that spinal nerves are mixed nerves, so so they have both sensory and motor function. So we have some things like bladder and bowel dysfunction, saddle anesthesia, which is where you can't feel the areas of your bum that you would typically like sit on a saddle. So in a clinical exam, it's important to ask bladder bowel dysfunction because we're looking for cauda equina syndrome. Whereas conus medullaris is, as we said, the ending of the spinal cord. And if we have a lesion around here, it also causes some similar symptoms, but there's a few differences in that we have like a loss of Achilles reflex, but not patellar reflex. This is not high yield at all. Just remember cauda equina syndrome below L2. Next is abnormal spine morphology, which you'll cover in clin skills. There's kyphosis, which is thoracic curvature over here. Lordosis is when you look like a lord and you walk with your back upright, a bit too upright, because your lumbar curvature, because the lumbar spine is like way too curved. And then you have scoliosis, which is like a lateral curvature. People don't really know why it happens. And a cervical spondylosis, which is a decrease in size of the intervertebral foramina because of degeneration of the joints to the spine. Basically, this causes a lot of pain instead of making you look strange. So another one is ankylosing spondylitis, and this is an inflammatory condition, basically. And eventually what happens is that your vertebrae fuse together progressively because of more inflammation, and people don't really know why it causes it, what causes it, but just remember it's the fusing of vertebra. Disc herniation, as we talked about before, is when the nucleus pulposus gets out because there's a tear in the annulus fibrosus. Bulging is just when it's about to tear. Herniation is when it's completely teared and it's compressing the spinal nerve root. Next is sciatica. If you remember, the sciatic nerve is this big boy nerve, the biggest in the body, that goes down from the lumbosacral plexus and travels all the way down here. So if you have a herniated disc pressing on the roots, you're going to have pain all the way down your leg. These are not really important, but there's also a couple of conditions like spondylolisthesis. And this is when you have chronic trauma of your back, and eventually you need surgical intervention because your vertebrae move out of place and can crack. But yeah, that's basically it. Don't stress too much about back anatomy. It's pretty low yield. Just remember the vertebrae and remember some of these clinical, especially cauda equina syndrome, and you guys will be all good to go.
Okay, so let's just go right into our next section, which is pain farm, and we're just finishing off what we started in week 7. And so we'll be looking at local anesthetics and opioids. So local anesthetics. So just a quick bit of revision. This would be, again, from around week 7 when we talked about pain fears, but also last sem when we talked about neurotransmission. So you have your up and your rapid increase in sodium permeability when your voltage-gated sodium channels open, and this depolarizes your membrane. And then we have your down when you have that increase in potassium permeability, which hyperpolarizes the cell and limits the duration of the action potential. So what local anesthetics do is they bind here to the intracellular part of your sodium channels. And so what that does, if it's blocking it, is it doesn't let depolarization happen. So it stops the sodium influx into the nerve cytoplasm. And two important things to remember are that it's reversible and it blocks sodium channels only when they're open or active. Everything in bold, I'd say, would be your key things to remember about local anesthetics, but it's quite a simple idea that if you block something, it's not going to let the sodium channels through, and if that doesn't happen, the action potential isn't going to propagate. A bit more information. So the key factors that affect local anesthetic action are lipid solubility and potency, which affects their potency, things like ionization status and pH. So for example, the more lipid soluble it is, the more strong it will be in its effects. The order of blockage, this is another common exam question. Now, if you remember back to your different nerve fibers, your C fibers are the thinnest. They have no myelination, so they're easier to block than the large fibers. Now, C fibers transmit pain. So pain will be the first thing that is blocked. And it goes pain, cold, warmth, touch, depth, pressure, motor. And that's kind of what slowly gets blocked in that order. And it recovers the opposite way. So pain would be the last thing that you feel. Adverse effects, just what's there, drowsiness, paresthesia in your tongue, mouth, auditory, muscular, seizures, a whole bunch of things can go wrong, which is why it's important to definitely administer and consider the patient as a whole, but it's not too important right now. Your core drugs, these are from ePharm. Lidocaine, again, the same mechanism of action. It binds to the inside of your sodium channels, inhibits influx and depolarization, and it's reversible. Bupivacaine is, again, same mechanism of action, but it's got a longer duration. It's cardiotoxic. And tetracaine is an ester, so it's rapidly broken down by plasma esterases and it has a shorter half-life. And its adverse effects are related to that with skin transient localized erythema. It can also cause damage to your eye and allergy. And if we look to the right, just a quick comparison of amides and esters. So amides are longer lasting, they have hepatic metabolism, and they're generally considered safer. On the other hand, esters have more rapid actions. They're metabolized by plasma cholinesterases, and it's more likely to have systemic toxicity. What Richard told us in terms of memorizing was that if there's an I before the ain part, so the I here, then it's more likely to be an amide, whereas tetracaine, as you can see, doesn't have an I. And again, this isn't a 100% reliable method, but I guess if you're not too sure, that's like one way you can try to suss it out. Okay, opioids. So opioids are opioid receptor agonists, and they can act either on your ascending or your descending pathway. And what opioids do are they mimic enkephalins and target receptors in your spinal cord and brain. Now, there are different types of receptors, but the main effect of the analgesic effect of opioids are from the mu receptors. And activation of opioid receptors inhibits the transmission of pain signals, and this can be endogenous or exogenous. So endogenous are kind of what's already in your body, such as endorphins or enkephalins, whereas exogenous are externally synthesized, and what they do is they bind to the opioid receptor and mimic what would otherwise be an endogenous effect. So, opioids. There are different targets in your spinal cord here. You can have its synapse within the dorsal horn, and in the dorsal horn, it has a lot of endogenous opioids, which inhibits transmission. Whereas centrally, in the periaqueductal grey matter and the thalamus, they're also enriched with opioid receptors. And again, that inhibits the sensation, but the descending pathway. And the descending pathway sort of stops the transmission of your sensation of the pain. So as you can see here, this is your opioid receptor, and this is the impulses that kind of tell this pain sensation to stop and not continue transmitting so that we don't feel the pain. Whereas if this wasn't working, then this signal would continue and we would feel the pain. And how it does that is these neurotransmitters, so usually things like enkephalins or endorphins, are released, and what they do is they hyperpolarize the cell. They open up these potassium channels, so it hyperpolarizes. So remember, it goes down too much. And it also inhibits calcium from coming into the cell. And if that doesn't make sense, that's fine. The key thing to understand is that it's binding to mu receptors and inhibiting the transmission of the pain signals. So the pharmacological effects, there are quite a lot because it acts on the spinal cord and it acts centrally. Obviously, you have analgesia. You can also cause euphoria, dysphoria, sedation, the slowing of the GI tract, and that is particularly evident in loperamide, and that can cause constipation. It can cause nausea and vomiting, and by stimulating the chemoreceptor trigger zone, release of histamines and associated symptoms with that, and of course addiction and dependence. Adverse effects, the main thing to remember here is acute overdose can be treated with naloxone, which is an opioid receptor antagonist, whereas opioids are opioid receptor agonists, so it just has the opposite effect. Your core drugs, morphine has a very high neuroaffinity, and it works the way we've been discussing. It inhibits pain transmission of the dorsal horn and activates the descending inhibitory pathways. So I guess it acts both ways. So it stops the pain from being sensed, and it stops the descending pathway from telling the body that it's feeling pain. Fentanyl is synthetic, and it's a lot stronger than morphine, and it has faster onset, but it has a short duration. So it's particularly good for things like breakthrough pain, but not so good for long-term use. Codeine is a weak opioid. It doesn't have as strong an affinity for the mu receptors as morphine does, and a little bit of it is converted to morphine inside the body. Loperamide, again, an opioid receptor agonist. This is poorly absorbed in the GIT. So that makes it a very good anti-diarrheal because it has no analgesic activity. I guess it kind of just stays in the stomach and it has all its actions in the stomach. Because it's an anti-diarrheal, its adverse effects are constipation. Naloxone, the other one, again, we've discussed this before, it's an opioid receptor antagonist, so it's very good for opioid overdoses. The only other one we would mention is tramadol, which has an analgesic effect from the inhibition of NA and 5-HT in the dorsal horn, which inhibits the nociceptive transmission, but again, adverse effects from increased 5-HT, so causing nausea, vomiting, yeah. And we'll put up a farm quiz afterwards instead of trying to get through the questions right now.
Okay, yep, so I will be taking you through the last bit of population health, which I think you guys are still covering, but we'll just do all of it in one go. So feel free to come back to this as you learn more pop health if you're confused about what's going on. And it all sort of links in together pretty nicely. Well, not super nicely, but yeah, we'll just go through this. Okay, so this is sort of leading on from what we ended with last session. Last session we did pop health, which was all of the different study types. So I'll just define the population parameters just in terms of what they mean when they're referring to these things. So when you have a parameter, it's basically just a value that summarizes the characteristic for an entire population. So you've got all these people, and that is a value that summarizes like a certain thing for all these people, let's say like mean height. So you might be thinking like how is this different from like your sample statistic? So your sample statistic is like an estimate of this parameter. So you're taking a sample from the population because it's not realistic to interview and find the result for every single person. So you take a sample statistic to approximate your parameter. So the distance between these two values, because it is an approximation, is your standard error. So as you can think, as it makes sense, if you have a larger standard deviation in your parameter, you would have a larger standard error because like that curve is more spread out and there's like a bigger range in like what values people can take. And you can also think that if you have a smaller sample size, that could also increase your standard error because instead of sampling like 50 people, maybe you're doing 5. So then it's more likely that you're going to be getting an error. Like there's going to be a bigger difference between the sample statistic and the population parameter. A confidence interval is the interval that you have around your sample statistic, which will likely capture the population parameter. And it's usually reported as like a 95% confidence interval, which basically just means that you're 95% sure that the interval around the sample statistic will capture the population parameter. And there's a lot of like other stats stuff you can go into for this. So feel free to like hit us up on Curious Cat, whatever, if you do want like the stats explanation of how confidence intervals work. But for like med, I think this is pretty much all you need to know. So you can also use a confidence interval for like finding the difference between two means. And this isn't that significant. It's just for you to know that if your 0 isn't included in this interval, it means that there will be a significant difference because the other way around, if there's a 0, that means that there's like the two values are the same. And with like general convention, they like to use Greek letters to represent population statistics and letters for sampling. And it's just important to make a distinction between population and sampling in your head, as we said before with parameters and sample statistics. Okay, so one of the things that they do to see if like you accept or reject like your hypothesis in terms of like, is there a significant result here, is to do hypothesis testing, which is essentially just a thing that you do to determine whether or not your true and observed results are different. So you've got like a null and alternative hypothesis, which sort of helps frame like how the type 1 and type 2 errors work. But essentially the null hypothesis is like your default. So it means that there's no difference in the population. So there's no association between two things. And an alternative hypothesis is that there is a difference between the observed and true result. Okay, so with a type 1 error, you reject the null hypothesis when it is true. So because the null hypothesis is your like negative, you've accepted H1 instead, which is your alternative, and that's your positive. But because it's not actually supposed to have been accepted, you end up with a false positive. The type 2 error is a mistake of not accepting the null hypothesis. Is a mistake of accepting the null hypothesis when it is not true. So that is saying that you're accepting this negative when it's not true. So therefore it's a false negative. You should have accepted H1, which would be your positive result. And I think the knowing that false positive and false negative are associated with these two errors is important. I think it might have come up in one of our papers. But I suppose you can also think of it as like, remember it with like this meme, which is like, yeah, I don't know. It sort of just makes sense with like false positive and false negative. But if you need to think about like how they associate, it's just like when you tell someone that clearly isn't pregnant that they're pregnant, and then you've got type 2, which is telling someone that's clearly pregnant that they're not pregnant. Yeah. This just kind of requires you to sit down and like have to think about it, but it does make sense if you do that. So this is just like a brief kind of overview of how data is distributed. I don't think you need to know too much about this, but when you've got a negative skew, when you've got like a lot of values on this side which are like on the lower end, which means that your mean will be pulled down because you've got all these small numbers, but your median and mode won't be affected as much. And with the other side, it's just the other way around. You're gonna have high values that will pull your mean up and not affect your median and mode as much. So then you've got your mean that's shifted, that's greater. Yeah, so they don't line up like they usually would if there wasn't a skew. Okay, so types of tests that you need to sort of know. So this was something that was really confusing for us. And I'm sure, I don't know if you guys have covered it yet, but man, it's confusing. But we'll try to summarize it here in terms of like what it's used for. And I think this is examinable. So as long as you like remember what it's for, you should be okay. Like if they give an example, you can think like, what am I looking and what am I looking at, and what are they like actually testing? And then that sort of leads you into figuring out like what test you would use. So a one sample t, so this is all for continuous data. And so a one sample t-test is literally just looking at your sample mean and then a hypothesized value. So it's like a one thing. A two sample t-test is comparing two means from separate groups. So remember that they have to be separate groups. So that would be like male versus female, mean height, or like male versus female, like mean blood pressure. And sort of along the lines of that, you've got a paired t-test, but instead of having separate groups, you have the same group. So it's the same person. An example of that would be like cholesterol levels before and after treatment. And you can also do this for more than two groups, but then that would become an ANOVA test. So yeah, so it's like a similar concept, but it's called a different thing because it's got more than two groups. So there are also a number of tests that you can do for categorical variables. And the first one is the chi-squared. So it literally just looks at the association between two categorical variables. And you can have multiple like options within the two categories. Like for the profession, we've got 3 here, and smoking would just be yes or no. And they've got an odds ratio, which I think you would have looked at back when you covered like the different study types. But essentially, so there's the formula for it. And I think this would have been covered to death like in class. But yeah, and essentially it's just if your odds ratio is below 1, the odds of your exposure among the cases are less than the controls. And if it's over 1, it's like bad stuff because it's you've got higher odds of exposure among your cases. It's likely that your exposure is linked to the cases. I've got relative risk, which has also been covered in the study design part because you've got cohort studies and randomized control trials that both report their outcomes with relative risk. And this one just compares the probability of getting your disease if you're exposed versus the probability of getting the disease if you weren't exposed. So again, that should say larger than 1, my bad. But if it's less than 1, then it's decreased risk. If it's larger than 1, then it's increased risk. So in both cases, if it's larger than 1, you're going to have like greater risk if this person's been exposed to the thing. Okay, and then the hazard ratios, I don't think we mentioned this that much in class. Like I had to think about it and I don't feel like it's used that often, but it essentially just measures instantaneous risk rather than cumulative. And I think the ratio is calculated by looking at like a hazard number between the intervention and control groups. I also don't think we've ever had to calculate this. So it's one of the less important ones, I would say, from these tests. Okay, so you can also do like regression. So you've got 2 types of regression. You've got linear regression and logistic regression. So I'm sure you've heard linear regression from like math and all that. So it's just like the relationship between X and Y. And you've got an R value, which looks at like whether there's like a really strong correlation. So closer to 1, the stronger the correlation. And like, I think 1 is literally just like a straight line. So simple linear regression is like what we classically know from math. It's just an X and a Y. A multiple linear regression is like a 3D kind of thing. It's like high key, you can't picture it because there's so many. So it's just where you have a lot of X variables. So instead of 1 X and 1 Y, you have many X's and 1 Y. And that gets confusing because you've got so many X's. And I think because of like how that works, it just turns the graph into like a 3D, 4D, I don't know, beyond dimensions kind of funky thing. So, but yeah, all you need to know is that there's more than 1 X variable here. So you can take into account multiple things like height, gender, etc. A logistic regression, I've just put a graph here showing what it looks like. And so you have a continuous independent variable and a categorical dependent variable. So the categorical dependent variable would be like, I suppose like it could be like yes or no, or like diabetes or no diabetes. So this sort of like reflects that as well. You've got like this, I think this shape is supposed to be quite classic for logistics. So you've got your like independent variable here, which is continuous. So your plasma glucose can vary anywhere between 50 to 200. And then you've got like your categorical variable here, but this is reported as like a probability. So it's either high probability that they are diabetes positive or like very low probability that they have diabetes. And this shape sort of lends itself to being quite suitable for that. Because once you've hit like a number, it like accelerates quite quickly and it tapers off at the end. Okay, so something that's fairly applicable to life right now. So this is just like sort of definitions for what these words mean. So you can have an epidemic / outbreak, which just means that you have more cases than you expect in a specific group at a particular time. So just it's quite focused in definition on like where, when, what, etc. A point source epidemic is a type of epidemic in which you have a lot of people exposed simultaneously to one source of infection, and a pandemic is a epidemic that has crossed borders. So once it like stops being contained in that region and goes elsewhere, it becomes a pandemic, which is what happened with COVID. You've got a cluster, so which is like a group / aggregation of cases. Ooh, my bad. Let me go. Please, no. Okay, a cluster group aggregation of cases, and you've got endemic, which is like when something only really occurs in a specific area, and it's got a fairly like stable pattern. So it's not like a spike or anything. It's just this thing happens in this area. So I think an example of that would be like malaria is endemic to certain areas in like Asia. So it's like always there, but it's only always in that place as well. Okay, so you've got disease history. So I think the definitions for this you honestly can just remember, like latent, it's just chilling there. And then infectious, you're infectious. Incubation, it's also just chilling there. Yeah, and then symptomatic is when they have some, like symptoms. But I think the main thing to know is that when there is a disparity between these two like sort of timelines, you can be infectious without being symptomatic, and that's where things are dangerous because you don't know you're sick, but you're transmitting it to other people. Okay, some more definitions that you might want to know. So index case is the very first case in the population, so you might not always know who this is. You might not be able to trace it back. Your primary case is sort of similar, but it's the one that you do, it's the first identified case. So they may be the same person, they may not be the same person. You've got secondary case, which is just cases from like subsequent transmission if primary case passes it on to someone else and someone else passes it on to someone else, etc. And reproduction rate is just the number of cases that one case generates over the course of its infectious period. So as you can imagine, if you have more cases generated, then the disease is pretty bad and you would get higher numbers. And if it's lower than one, then you would see it like taper off because one case leads to less than one case. So the immunity is just the capacity of a person to remain free of infection, and herd immunity is just this concept but applied to like a whole group of people. Okay, epidemic curves. I don't know if this was like super examinable, but they talk about it in like Etude, so it's here. You've got different types of like ways things spread, and they have like unique curves to show like how that sort of works. So you've got a point source, which is just like one person has it, and then yeah, it spread, I suppose. Got a common continuous source, which apparently the plateau here corresponds with the duration of the exposure. And they've got a propagated source, which is like a lumpy kind of pattern because it's transmitted between people and there's like incubation period and all that. Okay, so this is like by far the most high yield of like pop health, I would say. There will be guaranteed 4 questions on this. And if you understand this, you can get those 4 marks like easy. I don't know if you guys have covered this, so come back to the slides. If you've covered it, you're still like, what the genuine fuck. But sensitivity, so okay, yeah, okay. So I'll just run through the definitions first, and then we'll see how this is applied, and like, is it like a question? So sensitivity is the proportion of people that have the disease and test positive. So you've got the true positive over the total number of people with the disease. Specificity looks at the negative side. So people that don't have the disease and test positive, and test negative. So the true negative over the total number of people free from the disease. So this is kind of hard to remember because the 2 words high key sound the same and they both start with S. But here's a really bad way to remember that I use. So sensitivity has an N and specificity has a P, but sensitivity looks like positive results and specificity looks like negative results. So you just look at the N, you're like, okay, that doesn't work, so it's P. And then you look at the P and you're like, oh, that doesn't work, so it's an N. It's kind of the worst thing I've ever thought of, but it works for me and I probably won't work for you, but it's here anyways if you want to use it. I reckon like working backwards might make more sense. So positive predictive value, it essentially looks at, so because it has the word predictive in it, you can kind of think, so you diagnose people with a thing when they have a test, right? And when they have a positive test, like you're thinking, how predictive is that of whether they actually have this disease? So then this value means that it translates into being the proportion of people with a positive test that actually have the disease. So true positive over the total with a positive test. And similarly with negative predictive value, if they have a negative test, how predictive is that of them actually being negative and not having the disease? So then that would translate to being true negatives over the total with a negative test. This might not make sense still, so we'll jump into like an example. So in terms of specificity and sensitivity, so we remember that sensitivity is if you actually have the disease, how likely is it that you'll test positive? So then you look at this column, because this is like how it's split up. So you've got the total that people that have the disease, and you've got the people that, out of those people that have tested positive. So that gives you your sensitivity. So it's this number divided by this number. And with disease absence, you've got the total number of people that don't have the disease, and then the people out of those people that have tested negative, and then you divide that by this, which gives you specificity. So because it's like, I think it's supposed to be like a feature of the test, it doesn't change with how prevalent the disease is in the population. So this is slightly different for the positive predictive value and negative predictive value. So you've got, as we sort of discussed before, you want to look at all the people that have tested positive for PPV, and you want to think, how likely is it that they actually have the disease? So then you would do true positives divided by the total with a positive test. And with negative predictive value, you're thinking, how likely is it that someone that's tested negative actually does not have this disease? So then you would go true negatives divided by total with a negative test. So these two values, it's important to know that they change with prevalence of the disease. So in a setting where there's like really low prevalence, you're going to have a low PPV and a high NPV. And it sort of just makes sense if you think about that. So when you have low prevalence, it means that very few people in the population have this thing. So a positive predictive value, if you have a positive test, it's unlikely that they'll actually have this disease because it is like really low in prevalence in the population. So therefore your PPV would be low. And sort of along the same lines of logic there, if you have an NPV, it's quite likely that them testing negative means that they will actually not have this disease. So therefore your NPV would be high. And if you just kind of reverse that logic, it makes sense for high prevalence as well. So this has implications for like what test you'd be using if you were screening versus if you were diagnosing. So a screening thing would be likely to be more low prevalence than diagnosis, because diagnosis means that this person has already presented with something and you're concerned. So you're like, okay, I'm going to figure out what this is. So it's likely that there are going to be more cases in that population. So yeah, it's just something to keep in mind, I suppose, if you're thinking about that. Okay, so onto screening requirements. So I think this is just like a brief overview of like what would be desirable from like doing screening. So your disease should be pretty well defined. You should know how prevalent it is, and you should have a long period between when the disease can be detected and when it will actually present. So that sort of just makes sense as well, because if you have something that like, if the time between these two things is like 1 day, there isn't really much point in screening it because you would have found it out anyways from like them presenting with it. And the disease should also be pretty serious. So like you wouldn't want to screen something and it's like, oh, it's pretty chill, like it's not that bad. And then treatment needs to be available as well, because you also wouldn't want to screen and be like, oh, you have this disease, but we also can't do anything about it. So you just have to live with it now, haha. Okay, so that's all for the disease. For the test, the screening test should be pretty like simple and safe, and it should be able to distinguish between who has and hasn't got the disease, because if you have like a crappy test, it's also kind of not worth doing. The screening test should also be cost effective, and there should be equity of access to screening. And just, I think healthcare access, just to have equitable healthcare access is important in general. Okay, so onto the biases. So you've got two main biases that you sort of need to know. So you've got lead time bias and then length time. I remember struggling so much with remembering which one was which, but like another kind of shit way to remember this. Okay, this is not a shit, it's the other one. But lead time, early detection. So there's a D in lead and there's a D in detection. And then you've got length time, which is G and G. But essentially lead time is when you detect the disease earlier because you've screened it, but you actually don't change how long they survive for. So let's say someone was going to die at the age of like 30. If you hadn't screened it, they would have presented at the age of 27. But because you have screened it, you've like caught it at the age of 25. But in both cases, they've only lived till 30. Like you haven't been able to change the course of the disease. But it just seems like they've lived longer because instead of living 3 years after diagnosis, they're now living 5, even though they still only live to 30. So length time bias is essentially where you're only really detecting diseases that are slow progressing, because like this diagram sort of shows it. So you've got this time period in which you're not doing the screening, and then you do. So when you screen it, you're likely going to be missing the things that grow really fast, but also the things that grow like really slow. So yeah, it's that you're just, the ones that you do catch are going to be the ones that are like kind of just chilling there. Like they're not going to kill you super fast. They're also, yeah, it's just because of the nature of the ones that you are detecting and catching, it's going to lead to a bias in terms of like what you think you're actually, like the impact you think you're making with the screening. And overdiagnosis is something that you do need to keep a watch out for, because if you screen someone for something that they would never have known about, so I think examples of this include like breast cancer. There's certain types where it would have been fine if you just had left it. It may lead to overall harms instead of benefits. Okay, and levels prevention. So I high key still don't know exactly the difference between primordial and primary, because the way they explain it and the like past paper questions, it just seems like the two are just so blurred together, and like some examples come into primordial, but the same example sometimes also comes into primary. So like bro, high key, who knows? But I think, from, if anyone wants to correct me, go ahead. But I think the primordial is supposed to be like targets some very upstream stuff, so like social economic determinants of health. So the cause of the causes. The examples here kind of also don't really work. I don't know. It's whole thing is just very confusing. But primary, I think, is less upstream. It's like one step down from that. So it targets the asymptomatic individuals. Although I also don't really know like how they're figuring out who's asymptomatic. It's just everyone. Both primary and primordial is just like big scale like things that you target to hit everyone. But after that, secondary, it gets easier from here. So secondary is literally just screening. When you try to detect the disease early, if you see the word screening, it's secondary, and that's something that the PSPs from our year like hammered into us. It was like secondary screening, secondary screening. Okay, and then tertiary is like another step from that. So this person's already started presenting with like symptoms. So you're just trying to like mitigate the damage from like them having that disease. So an example of that would be like having surgery for people that have coronary heart disease. Okay, so we're on to some questions. Let me just pull up the chat. So this is high key. Oh, put a chat. Yeah. So you've got, yeah, just chuck your thing into chuck your answers into the chat. But this is pretty much how the exam is set out. You're going to have a table, and they're going to be 4 questions on solving sensitivity, specificity, etc. So might as well give it a shot now. Yeah, we've got these. Perfect. So yeah. Also worth taking note that they sometimes might switch the 2 like columns and rows around. So you have to like really read it and think about what the definition is, because otherwise if you just always go like, you know, it's just the column or it's just the row, you might get it wrong. Oh no, did I not put the answer in? Oh no, it's here. Yep, cool, nice. Yep, looking good, guys. Yep, cool. Yeah, you guys are set. 4 questions, nailed it. All right, one more question for pop health. Anyone want to give it a shot? Yeah, cool, perfect. All right, on to the last section of today. It is getting a little bit late, so I will try to get through this as fast as I can. Also, microbio is really just like remembering it. There's a bunch of explanation. Okay, let's jump into it. So viral pathogenesis. Viruses are not living. Yes. So you sort of need to know how they like multiply in the body, and that's summarized here with like APGAR. It sort of just makes sense from like if you think about how viruses need to replicate in like a body, so they have to get into the cell, they have to and then do the gene things and then make things and then leave. So yeah, it's yes. But I think you need to know like the exact like names for it, which is why you've got a mnemonic here, APGAR. Okay, outcomes of a viral infection. You've got 4, I think, outcomes that you can get from a virus. So either it can turn into cancer, which is bad. It can kill your host cells. You can get like persistent infection. So it's just like constantly you've got this like viral load in your body. And you've also got latent infection. So it like just chills in your body cells, but it can come back out and like fuck shit up. Okay, immunopathology is essentially just like your host response to the infection that causes it to damage. So the virus itself isn't doing anything. Well, it is. It's not like outright causing damage to your cells. It's the response that it causes in the immune system that leads to like huge damage. So an example of that would be like dengue. You've got your antibodies that have been created in your first exposure, and getting subsequent exposure to dengue means that you end up with this huge viral load and your immune system goes absolutely crazy, and you have like plasma leakage, hemorrhage, and all of that bad stuff. Okay, so we're going to run through like a couple of viruses that you talk about in class. So I think this is all covered in like week 7 for you guys before midsem. So I guess this would be like a revision kind of thing as well. But you've got the way that the way they classify it is just by like the genome that they have. So either it's DNA or like RNA. And I've sort of put the central dogma back in here just to remind you guys of like how proteins are made in like a cell. And also because I had high-key forgotten, it's been a while. Okay, so we're gonna go through, we're gonna go through DNA viruses first. So because these have DNA, it's pretty easy to make mRNA from DNA because you've already got all the stuff in your body to do that because you're naturally already making mRNA from DNA. So some things that can do this are herpes, and the outcome of this is like latency. So once you have herpes, you high-key always have herpes. So HSV1 is the one that's oral, and HSV2 is the one that's genital. And from what I think, just from like, I guess not common knowledge, but from just a general understanding of how herpes works, it's the one where you have like lesions everywhere, and the person's really only infectious when they have these lesions. So when it's like chilling and you don't have any lesions, you don't transmit it. Okay, so the second one is HPV. You might have also heard about this from like the HPV vaccination, which is used because this thing can lead to cancer. So you've also got 2 types where you've got genital warts and you've also got skin warts, and the genital one is the one that you're concerned about for like cervical cancer. So the way it actually transforms into cancer is that the viral proteins that it has interfere with your tumor suppressor proteins, so like the things that you covered earlier in the year with like P53RB. And when you lose these like breaks, you end up with like huge growth and like hella mutation. And that eventually leads to the development of like bad cells, which are, leads to cancer. So as a result of that, genital warts can lead to cervical cancer. Okay, RNA viruses are slightly different from DNA viruses because they are like, they're RNA. So like the sugar thing is a little bit different. You can tell I don't remember anything from first year. Okay, so your ssRNA is exactly the same as mRNA. So it can be used directly to make proteins because that's how proteins are made. Your mRNA is like the thing that leads to the protein being made. But it also needs to replicate the ssRNA because it needs to like make sure that it has more ssRNA to use for future replication. So it does this by making like an ssRNA negative sense strand and then using that to then synthesize ssRNA again. So you just need both of those strands for it to continue to do its thing. An example of this is Hep C. So this is like huge in the injecting drug user population and infects your liver. So bad liver vibes if you've got Hep C. So the outcomes of this, there are a couple. I don't think it's that important to know, but I guess it's just like to know that you can either have like a chronic infection as shown here, or you can have like an acute where it is cleared after a little bit of time. I guess you can also get super infection, which is when you get a different type of Hep C infection as you're still clearing the other one. And you can also get another different Hep C infection after you have cleared it. So I guess it's just showing that you can be infected by multiple different types of Hep C in one go. So the way to treat this is to just prevent the virus from doing the virus things. So you stop it from encoding, you stop it from making things, you stop it from like doing things it needs to do in terms of like RNA polymerase, and you prevent it from like leaving the cell as well. Okay, so ssRNA negative sense strands. So this is sort of similar to the positive, but it's just the other version, like, because you have your pairs and all of that shebang. But because this is not mRNA, you need to use RNA polymerase to make the positive sense strand, which would be equivalent to mRNA. And the positive sense strand is also needed because you need it for replication to make another negative sense strand. An example of this would be influenza, which is like your flu. And the bad thing about influenza is the ability to like trigger the immune response. So you have like hella immune stuff, which is not good. And I think one thing to know for influenza is that it's got this protein on the outside called hemagglutinin. Maybe it's not a protein. It's got this thing on the outside that's hemagglutinin, and it binds to our cells and allows for virus entry. So once you see this, just know that it's the thing that's used to get into our cells. And I think this was in one of the Moodle quizzes, which is why it's been put here as well. So last section is retroviruses. So these are RNA viruses, but they need to be converted into DNA and then back into RNA, which means that they need like these RNA/DNA polymerases to go from RNA to DNA, because that doesn't happen in the body. DNA goes to RNA like in pretty much every process in the body. So you have to bring in your own polymerase to allow for RNA to DNA stuff to occur. So for sorry, a lot of retroviruses, they want to integrate the DNA into our own cells. And they need to bring a bunch of like specific things for that. So like integrase and protease. An example of a retrovirus is HIV. Like you can sort of think about that when you think antiretrovirals, which are for HIV, because this is a retrovirus. But it essentially like messes up your like immune cells. So let's say you're like CD4 cells, macrophages, dendritic cells. And because it destroys these immune cells, you're going to have a very weak immune response. And that's sort of like what leads to AIDS as well, because you end up with really low CD4. And that puts you at risk for things that wouldn't otherwise affect other people. And again, you would treat this with antiretroviral therapy, which may have been covered in like an ICL. And yeah, last time or something like that. Okay, oh, we're almost there. So last section of today is skin and MSK. Yeah, so this is, I would say it's not that high yield, but it's here for completion's sake. And there's a lot of stuff that occurs in the body. Okay, so Staph aureus literally causes everything, but the two that they highlight in the slides is scalded skin syndrome and toxic shock syndrome. I'll just let you read through that. There isn't really much to it. And the strep progenies can also do two unique things: scarlet fever, and also can do toxic shock syndrome, because they both produce exotoxins. So bacterial infections of the skin include cellulitis, which goes through subcutaneous tissue. So knowing the location of where this goes through is really important, because I think that's the most examinable part. And necrotizing fasciitis goes through all layers, because it's the one that's like very intense. It just necroses everything. We've also got gas gangrene, which is a key like word for Clostridium perfringens. And you've got acne, which is infection by Cutibacterium acnes, which used to be called something else. So I think that some like resources are not up to date, so they still call this old name, but I think they're the same thing. Okay, so leprosy, you've got two types. You've got tuberculoid and I don't know how to say that, lepromet. Okay, I'm not gonna bother. But they are just differentiated by how many like organisms you have, so, and that leads to different effects and like presentations. Yeah, you can read that. Okay, and fungal infections. This was so confusing for our year. I don't know why it was so confusing, but I've like sort of tried to summarize it here. And I still like don't really, Taiki, okay. So you've got psoriasis versicolor, which is a yeast thing, and that's usually caused by Malassezia furfur, which is a type of yeast. You've got this other thing, which is like fungus on your skin, and I think a number of things can cause that. And when it's caused by any of these fungi, it's just called dermatophytosis. And then you've got candidiasis, which is just caused by Candida albicans. I really don't think this is that high yield. It's just here for completion's sake. I feel like it'd be quite mean for them to properly examine you on like the fungal stuff, just because it wasn't very well presented either. Okay, viral infections. So a lot of this was already covered in the previous slide. This is just here because this is how like I think one of the later lectures was set out, and it mentions a couple of examples that weren't brought up before. So we'll just go through the ones that weren't brought up before. Yep, so VZV is one that wasn't brought up before, and this is literally just chickenpox. And I think you guys would have learned this, but it's one that can lead to shingles later on because it stays in like your body and can be reactivated. It's the way you treat it is acyclovir, and I think there's a way to remember this, like clover. It's like, I don't know. If you want to figure out how to remember it, there's probably going to be something in our farm slides. Measles was also not mentioned before, but you don't need to know too much about this. It's just very infectious, and you can have like a rash along with like the respiratory symptoms. Rubella, which is ssRNA, fever, malaise, rash. Don't think you need to know too much about that either. And you've got your hand, foot, mouth disease, which is just basically what it means. You've got like rashes and lesions on your mucosal surface. Muscle infections, you can either have viral stuff or you can have parasites. Yeah, these are just like the things that can cause that and the symptoms that you present with. And you've got bone and joint infections. So this is one that came up on our exam, but luckily Staph aureus is the answer, and everyone put Staph aureus because when you're in doubt, you Staph aureus it out. Yeah, but essentially it's bad stuff of the bone because your bone's quite well vascularized, so things can spread quite easily, and also it's like closely associated with your joints. So if you have pus in your joints, you can have like septic arthritis. And then you've also got your diabetic foot, which is just like the 3 things that can occur in your foot because of diabetes. Yep. Okay, what is this? Right, so some other things that you can get with like joint pain and joint inflammation. So the types of arthritis you can get, as we sort of discussed earlier, you can have septic arthritis, which can be caused by a bunch of things. You've got viral arthritis, and then reactive arthritis, which is where it's like a result from like your immune system going crazy, but your microbe isn't actually at that site. And this can be caused by infections in like your GIT. So for example, by chlamydia trachomatis. Okay, finally at the questions. All right, if anyone's still here, feel free to check in your answer. Not quite, but close. It's a very sneaky one because it says false. But subcutaneous would be for cellulitis, and necrotizing fasciitis goes through all the layers. Yeah, faculty also really likes to put things that are like, what is false about this? So everyone gets pranked into like putting the wrong answer. Yeah, okay, last question. Yep, cool, Staph aureus, you got it. Honestly, like, I think the life hack, honestly, is just, if you don't know what the answer is, it's Staph. All right, cool, that's it for today. As always, if you have any questions, hit us up on like Curious Cat or DM or anything like that. Thanks for coming.